top of your list, and let's just go through there. Oh, as you notice in highlight, do I have the vasopressors again? Are you guys ever gonna get away from your vasopressors? I don't know. But you know why this is good that you see them again? Because they're life-saving, aren't they? They are life-saving. What do the vasopressors do? They constrict. Very good. They compress the vessel, right? They're compressor. We have, again, just as a class as a whole, name some of your pressors. Dopamine, epinephrine, norepinephrine, dobutamine, midodrine. There's more. What am I missing? Oh yeah, as an anticholinergic, yeah. But those are, atropine is more about the pulse rate than vasoconstricting. Good point though. So, did I bring in class one day the vasopressor list?
Yes.
Yeah, oh, that's your good thing. Now, why are we gonna revisit this? Shock. Guess what we get to do tomorrow?
Shock.
I cannot wait. It's one of my favorite times is shock. And that's gonna be tomorrow in med-surg. That's why they're coming back. I don't mind, reiterating this over and over and over. Because in acute care, man, I'm telling you, it comes down to pressors. No, it doesn't matter if you're on med-surg, surgical. If you have your ACLS and you're on the right unit, you can give these ACLS drugs. Yeah. Okay, good. And then your cholinergic drugs are gonna be your atropine, right? And that's gonna be for things like symptomatic bradycardia. IV fluids, 0.9. Oh yeah. Is that the first thing that we give for shock? Distributive shock. Not cardiogenic or obstructive is going to be for distributive. Tomorrow, your shock, by this point, you guys are gonna know it. We've already covered shock from day one. But I do that purposefully, so when you get to week 10, it's like, wait a minute, I have an idea of what it's about. Widespread like SIRS, like septic shock. Widespread vasodilation, capillary neurogenic shock, widespread vasodilation. Anaphylaxis, what is it? Vasodilation. What's the other one? Oh, and then of course hypovolemic shock. They lack enough volume in the vessel. They're not necessarily dilating, but they have a lack of volume, which kind of is, in a sense, makes those vessels bigger. They don't actually dilate, but they have less fluid and more vessel. In other words, the vessels are not filled up. Does that make sense? Yeah, we'll cover that tomorrow. Then you have cardiogenic shock. Just think about this. What is cardiogenic shock? Heart. And obstructive. So there's two different forms, obstructive and then cardiogenic is a part of obstructive shock. And the way I like to look at it, obstructive shock is obstruction of blood flow. That's how I like to think about it. So let me ask you this, or let me tell you, some of the causes of cardiogenic shock, we'll go there, which is a form of obstructive shock, is heart failure. Remember cardiac tamponade? What does that do to the heart? It causes it not to be able to pump, fill, or eject blood out. So you have two things going on there. So pericarditis and tamponade. How about cardiac arrest? Duh. If you have an arrest, is that cardiogenic shock? Heart stop. So it's really pump failure for whatever reason. So the heart is not actually putting out any cardiac output. I want to ask you smart people, I want to ask you. So they're not getting cardiac output. And remember, And this will reflect to the treatments. Remember what shock is? Decrease in what? What was it? Yeah, which will lead to hypoperfusion, which will lead to shock if left untreated, multi-organ dysfunction syndrome, right? And then death, yeah, because once your organs die, human organism dies, right? So, are you going to give 0.9% bolus to a cardiogenic shock patient? And why? That's right. You're not getting an output because there's some sort of pump failure. Let's say mechanical failure, right? So no, you have engorgement of blood. It's there, it's not moving. You could actually kill them by giving them the 0.9 or the plasma, and that's next. Now, why is plasma on this list? What is it? Yeah, it's a volume expander. So what sort of situations would you anticipate giving plasma to? Traumas, yeah, blood loss, right? Hypovolemic shock. What we're trying to prevent is, in this case, hypovolemic shock for sure. And what other big things, since kids, why they're together? Burns. Did somebody say burns? I heard this at the end. Yeah. What happens in burns? Massive inflammation. Are you kidding? You have a 50% BSA from head to toe. So, occupational explosion burns all the way through the clothing, burns off the clothing, it's got to the skin, full layer. And now, what's going to happen? It's just like spraining an ankle. You have inflammation, the immune system takes over. Where does all that fluid move to? Traumatic burn, the traumatic tissue, right? And then, where does it steal the fluid from? The vasculature. What happens to the blood pressure at this point? It drops very dangerously and very quickly. So that the gold treatment with anything like this, whether it's trauma, hemorrhaging, burns is fast. We've got to get that fluid on board. And so the first thing with that is going to be looking at hypovolemic shock. And so we're going to get saline and potentially a plasma volume expander like plasma. And certainly if they're bleeding and going into hypovolemic shock, same thing. So we love plasma because it is that volume expander. Number two, for hemorrhaging, what does it have special that helps them with the bleeding? What is it? Clotting factors? Yeah. So remember that plasma is special. You sort of put that one aside. It's different from like albumin. I think this weekend I read, and I can't remember where I read it, albumin. Sometimes I'll give albumin to burn patients too. Because, yeah, exactly. It's a protein, it's that big, and then you were saying, Josephine, that those big proteins suck fluid in and it stays there. It doesn't go past the big molecules, don't go past the semipermeable. So plasma's going to do that, and albumin. So don't be surprised if you see a test question that says albumin for burn. We usually give plasma, either or, whatever they decide to order. Usually the typical indication for albumin is going to be for alcoholics, right, for the albumin. Is that going to be in the test? Yeah, it is. So that's why we have your body. So really, the best thing to know is the concepts behind it. Okay, let's move down. Oh, look, we've done our insulins already. I'm going to talk about how we give it. You know, because you guys should have learned that in lab. AH1, we covered diabetes. Let's go through the thyroid disorders. Okay, excellent. And I'll start giving an exam review right away. The need to know important stuff. So what is levothyroxine? It is a hormone. One word. Replacement. When you refer to hormones, it's either going to be a replacement or an inhibitor, right? Remember Lupron was an inhibitor, you know, to take down that testosterone so the tumor doesn't grow, that likes the testosterone. So you have inhibitors and you have replacement. It's that simple. It's not even rocket science at all. So you have your levothyroxine, Synthroid, they make it in the lab, but chemically it's the same, it's just replacement to treat hypothyroidism. We know that, so you future nurse practitioners, how do you know what dosage to order for your patient?
Their labs.
Yeah. Which lab? Yeah, T3 and T4, but also the TSA, right? So they will look at all of those, but especially the TSH is the biggest diagnostic for that. But this is what I want you guys to know, this round for Synthroid. When they get a new script, where do you even have them report to you? It's a brand new script.
Side effects?
What is it?
Side effects?
Yes, very good. And what are the side effects? Tachycardia. Yes. Huh? Weight loss. And that wouldn't be a bad thing, but it's not good for the heart. Insomnia. Good job, you guys. Palpitations. Heat intolerance. Yeah. All signs and symptoms of hyperthyroid. And maybe the dosage is too much for them. Okay? Can they go into an arrhythmia? Yeah. Like atrial fibrillation with RVR. Yeah. So this girl right here, I was taking my Synthroid every day. I was going, yeah, it's great. I've been taking it for years. I started having this heart problem. I said, oh, maybe it's because I'm getting old. Maybe those students are giving me so much grief that I'm having some arrhythmia. I really looked at all this, stress and everything, right? Do you know what it turns out to be? Synthroid. My dose was too high. When I went in there, did a TSH, it was scary because when you feel like you're gonna die, that's scary, right? RVR is not fun because you feel it pound. You think you're going in to be tapped, which you couldn't, by the way. That's just one arrhythmia. Tell your patients to report those. Somebody over here said palpitations is very important. That's an indication that they are having some sort of arrhythmia, the palpitation. Usually a tachyarrhythmia. Okay, so that's what I want you to know. I want you to know for educational purposes, this is part of the mantra, right? It could be an assessment, it could be an intervention, it could be a side effect, that's part of the material. Side effects, adverse effects, yeah, and education. So this, I think, is an education one. How to report. So what's the doc going to do? They're going to run under TSH. They're going to decrease the dose. Good job. I want to ask you guys. Next one's going to be anti-thyroid, right? Did I have PTU on a test already? I did. Did I save it for the next test? Okay, perfect, then that's good. So, propylthiouracil actually decreases the hormones, the T3 and T4, okay? And the radioactive iodine, did I decide not, we didn't have that on this test, right?
No.
I think I even said that I'm gonna put it on this next exam 4, which makes sense because there's more endocrine drugs on the next one. Okay, good, good. So they, what you wanna think about for those is they decrease thyroid function. Okay, so that's what they do. Or what are you giving them for? Hyperthyroidism, logically, right? So one of them is a replacement for hypothyroidism, they don't have enough hormone. The anti-thyroid drugs, they have too much thyroid hormone. So they're designed conceptually to decrease the thyroid function. And you look at radioactive iodine, it kind of makes sense because your thyroid hormones are partially made out of iodine. So you have to have a good amount, a balanced amount of iodine in the body, right, to have good thyroid function. Did you have too much iodine in the body and have hyperthyroid sort of symptoms? Yeah. If you have a lack of iodine in the body, you have hypothyroidism, or at least symptoms. Absolutely. But yeah. So you want to kill out those cells by either drug. Those are conservative measures, aren't they? What's the ultimate treatment for hyperthyroidism? Thyroidectomy, right? Very good. And then of course you put them into full hypothyroidism. Hopefully you can preserve the parathyroids. Okay, let's move down to ADH. So what's the other names for antidiuretic hormone? Yeah, vasopressin. So this is what nurses need to know. They need to know that vasopressin in high doses is a pressor, right? Hence the name vasopressin, right? But in lower doses, it is replacement. Now the replacement that we're going to talk about is going to be desmopressin. Now, out of the pathologies that you're going to be tested on for tomorrow, who are we going to give desmo to? Exactly. Don't you love that? There's a D in desmo, and then the disease is so diabetes insipidus and desmo, 2 Ds, right? That's perfect. And then, so desmo is going to be on your test in exam 4. So basically, do you need to know what you're treating? Yes. And I don't think I saw that in here. I haven't even looked at this piece yet. Oh, iodine containing scrub. Oh, I know what that is. Okay. Never mind. Okay, can we go back to some levothyroxine? Let's go back, because I'm sort of, this is the first time I'm sort of changing PHARM because I like these. These are really good. Last semester, did you guys learn about Synthroid? Yeah, a little bit. Now let me ask you something. Did you learn about how the things that you have to teach your patients, like take on an empties? Does that sound familiar to you? Has that already been tested? I think so. Because usually in PHARM, when they do those more basic ones, I like to cover the big, scary side effect. So CMS may test you on that, but I'm not going to. Take with a full glass of water, and for education. Besides teaching, and this will be on your test, the side effects of the tachycardia, the palpitations will be on your test. But is it also good to teach them that it's a lifelong thing? That they don't take it for a week, like a course of antibiotics, right? Did you guys learn that last semester too? That's lifelong therapy. Yeah, because you think about, they have a disease process. They don't make enough T3, T4, so it will ultimately be a lifelong. Okay, good. I'm just checking my notes as we go along here. Oh, I'm liking these people more and more. I'm sorry. Lispro, guess what their onset is? 5 to 15. Sorry. Okay, I know I'm skipping around a little bit, but I wanted to get this done and just go down the list here. Oh, yeah. Can I go back to insulin? And please write, these are on your, most likely gonna be on your test. I'm so sorry. Cause I wanna make sure that as I'm going down with the drugs, there's something that I might add and modify with your test. Oh, that is looking really good. And guess what? The 5 to 15 is in red. I think that just makes the day right there. And of course, monitor for hypoglycemia. We know that with all the insulins. That's a big no-go. And which insulin can you give give IV? Regular, right? Like your DKA patients will be getting most likely an IV, or maybe, so, but regular. And then, did you guys learn the lipo hypertrophy in the areas that you give it?
Yeah.
Yeah, did you guys learn that last semester? Yeah, these are all fundamental. I'm probably not gonna test you on that, but definitely, yeah, I do have a question with the IV for regular. Yeah, we think alike, like big time. Okay, what drug are we on here? Let's go to insulin, thyroid hormone. We did the T, okay. Mostly side effects and it's lifelong therapy. I have, let me see what else we have here. We have the, vasopressin and desmo, what it says here. They give, that's what they give, and this is going to make sense.
Wait, where are we on?
We're on vasopressin or desmopressin, okay? And in red, what we have here, and as we get closer to the test, am I gonna get more narrowed down?
Yeah.
Because I'm right now deciding what I'm putting under test, right? New stuff. Does desmo or vasopressin help the urine to be more concentrated? It does. Remember, we talked about that more than once, right? That ADH prompts the kidneys to concentrate the urine. And you know what they say here in red? Increased urine osmolality. Yes. Yes. And is that what we're trying to do for diabetes insipidus? Yeah, not only, see, they have a lot of it, right? And are we also trying to decrease their urinary output? That's what we're trying. And why do you care that we decrease their urinary output? Dehydration, potential hypovolemic shock. So that's what it says on these cards here. I'm loving this. They're designed to decrease urinary output, right? And to also increase the urine osmolality, to concentrate the urine, because you don't want hypernatremia, right? We'll go through that again. That's probably a big 10-4. My test question right now is, it's very simple, but we're gonna make it a little bit more analytic and rigorous. We're gonna say, my test question right now says, what are you treating with desmopressin? That's right, diabetes is too easy, right? So let's go ahead and do a question. What's the real purpose of giving it? To decrease urinary output and increase urine osmolality to concentrate right now. That's gonna be your, I decided right now that's what we're going to do. Okay, good. Mineral oil. Drugs. Oh, Fludro? Oh, Addison's, yes. So let's do that. So we know that the Desmo's gonna be there and the Vaso. So either one's gonna be on there. Glucocorticoid, yes. So we already had our corticosteroids, a lot, because we give a lot for different things, right? Now, what endocrine diseases are going to require that they take lifelong corticosteroids? Addison's. So what do the Addison's folk have deficits in? So corticosteroids, cortisol, and aldosterone. And sometimes, like I have a whole PPT, PowerPoint from a different text that has the catecholamines too, but they tend not to take. So really, HEI focuses on the cortisol and the aldosterone, right? So let's do this. Corticosteroids. Oh, we have an interaction in red with NSAIDs because they both can cause stomach upset. Can corticosteroids cause bone loss? Yep, we know that, right? Osteoporosis. Can you gain weight, fluid retention with corticosteroid? Have any of you ever taken a dose cup, a temporary thing? It'll make you puffy and very angry. A lot of road rage and lots of hunger. They really do, right? So you'll see the puffy face, the moon face, fluid retention if they have to take it chronically. And this has been drilled. How about some hyperglycemia? All of these are in red, by the way. Infection, yes. How about peptic ulcer disease? Is it hard on the tum-tums? It really is. So have you guys seen so far in the hospital with your AccuScanner has a look next to prednisone PO? I like that, P and the P. When you take it PO, is it hard on the tummy? Can it cause bleeding? So then what are interventions you as a nurse can do since it's so hard on the tummy? Take it with food, right? Take it with, or give it with food. Wait, what did you say?
Oh, like water.
Oh, yeah.
Water.
Water would be a good thing to get it down, right? But you've got to have the food to protect the stomach. NSAIDs too. NSAIDs and glucocorticoids, they're hard. They get on the stomach, the GI system. And guess what? This is going to make sense to you because we've talked about it. When you give exogenous corticosteroids, you actually suppress the adrenal gland function. Yes. Hence why you don't want to abruptly stop taking them because you were suppressed. You know, it's like when a person who takes heroin, what are they suppressing in the body? What's the endogenous opioids? What's the runner's high based on? Endorphins, right? That's what your body has. It's your naturally occurring endogenous opioids is endorphins. Like when you get hurt, if you get injured, your body's gonna crank out some endorphins. Not enough to alleviate it completely, the pain, but enough to where you don't go mad, you know? To where it's at least lessened, naturally occurring endorphins. So heroin folks, you wonder why they hurt so much, is because for years, or even months, they have suppressed the naturally endogenous endorphins. So you look at them and they're like, ouch. Especially when you go to poke them for an IV, they'll pull away because it hurts. It hurts.
I think it hurts them
the adrenal gland suppression. I like that. Because you guys have learned that, you have an idea. I think in your near future for glucocorticosteroids, we're going to do these. We're gonna do these. So what were they again? Osteoporosis. Yep, infection. Hyperglycemia, weight gain. PUD, specifically written here. Adrenal gland sufficiency. You know, they also have hypokalemia on here. Hold off on that one. Next time I see you, I will either put that on the test or not. Okay, very good. We're making some very good progress here. Do you guys need a break?
Yes.
Yeah. Geez, look at me. Like, what are you doing?